So, dear Chair, dear colleagues, first I would like to send my warmest greetings to all the online connected people, to my friend, if any, and probably also to my mother, who is probably trying to connect, but I don't know. If I can have the next slide. So, there are sometimes some challenges, not always easy, in the peripartum management of thrombosis, disclosures. And we shall evoke two situations. The first challenge is the management of acute VT very close to delivery. And we shall discuss on the interest of proposing transiently an inferior vena cava filter. So this is a case, a 33-year-old woman, her second pregnancy. She develops at 34 weeks plus 5 days a left common iliac vein thrombosis, very, very proximal, complicated by pulmonary embolus. And so we begin the traditional treatment with fractionated heparin twice a day. You have to anticipate the management of labor and childbirth. So a very easy question, would you insert a retrievable inferior vena cava filter? Yes or no? So maybe 50-50? So let's go on. Thank you. My proposed approach in this case, I would first try to evaluate the hemorrhagic risk of a full dose heparin treatment around childbirth, taking in account the existence or no of acute obstetrical complications, analyzing the risk itself of spinal anesthesia. If we think that the hemorrhagic risk is acceptable, okay, we can go on using only heparins, full dose, adjusted weight, without no modifications. And if we think that there is an hemorrhagic risk we cannot afford, we have to modify the treatment, maybe to lower the dosages or to stop heparin, to know if we need a complementary treatment, always performing an analysis of clinical risk, and if it is yes, to analyze the benefits and risk of proposing, transiently I mean, an inferior vena cava filter. So let's go on. What are the specific considerations around neuraxial anesthesia? So if we look at the risk of spinal epidural hematoma, we have very low level of evidence with a very high heterogeneity of reports. No case were recently described, but only on series in which patients received prophylactic fractionated heparin treatments. The guidelines themselves strictly contraindicate this kind of procedure while the patients are on high-dose heparins. You have to perform a 24 hours wait adjusted fractionated heparin treatment cessation, to consider waiting for more than 24 hours after the neuraxial procedure and more than 4 hours after epidural catheter removal before restarting fractionated heparin therapy. What is the impact of this kind of treatment on neuraxial anesthesia? We had the results of secondary analysis, secondary study to the strategy study itself, and in France, performed in France. And the conclusions were that the anticoagulant therapy at the time of delivery, in France I mean, do not limit access to effective analgesia, but with an increased rate of spinal and general anesthesia and a decreased rate of peridural anesthesia. What about the impact of weight-adjusted fractionated heparin treatment on postpartum hemorrhage? We have some data coming from very heterogeneous reports and reviews, which seems to be reassuring, with no difference in PPH, no increased rate of severe PPH, no increased blast loss volume, but that was only in women receiving prophylactic dose fractionated heparin. We clearly have no data concerning the use of weight-adjusted treatments, so we don't know. What about filter placement itself? If we go back to what is currently published, it can be proposed in case of recent venous thromboembolism. If you have an absolute contraindication to anticoagulation, in most of the cases, if you have a concurrent active bleeding, and of course if you have recurrence despite adequately made anticoagulation. What about vena cava filters and pregnancy? So in patients developing extensive VT shortly before delivery, in most of the cases within 2 weeks, and in other patients developing acute VT and who are absolutely contraindicated to anticoagulation, placement of a filter will occasionally be considered. And of course, proposing a transient filter would appear to be particularly attractive in that position. However, what do we know about the benefit and risk of proposing a filter in late pregnancy? The recent reports do not describe any pulmonary embolism, but it is also said that the physiologic changes associated with pregnancy may increase the risk of vena cava filter-related complications. And if we compare to what is observed in the general population, I mean the non-pregnant women population, we have a higher rate of complication with, for instance, a higher rate of failures of retrieval, with a cumulative increase of DVT and so on. In this case, you see, looking at the CT scan, that we had an inferior vena cava which was totally squeezed by the gravid uterus. So what happened? We had a spontaneous rupture of membrane 5 hours after the beginning of full dose fractionated heparin, so 11 hours after the last heparin injection. So heparin was stopped. We inserted a retrievable inferior vena cava filter using the right radial vein route. It was put in suprarenal position, of course, as in most of the cases. We did not perform any neuroaxial anesthesia. Childbirth occurred 10 hours later by vaginal route with no complication. We had no postpartum hemorrhage, okay? And we could resume fractionated heparin treatment 6 hours after delivery, and we retrieve the vena cava filter 2 weeks after VTE. So, if I want to summarize some take-home messages, retrievable inferior vena cava filter and pregnancy. First, the magnitude of the peri-postpartum hemorrhagic risk in women who give birth while under full dose fractionated heparin treatment is unknown. The risk factors are not fully described. Filter may be a solution when other anticoagulation is not possible, but with potential risk of complications. Risk-benefit balance of using this kind of filters should be assessed on a case-by-case basis, as always, and you can restart full-dose fractionated heparin treatments after delivery. The second question would be on the management of life-threatening PE close to delivery. Can we have any idea on thrombolysis? Sorry. So this is a case, 37-year-old woman, third pregnancy. At 35 weeks, she developed preeclampsia with no criteria of severity, no consequences. So we observed the woman, but she developed bilateral pulmonary embolism at 30 weeks plus 3 days. So we began full dose fractionated heparin treatment, but we also observed rapid clinical deterioration 7 hours after the diagnosis with hemodynamic shock, low blood pressure, and pulmonary hypertension. So the question is very simple. According to pulmonary embolism treatment options, would you recommend in that case immediate thrombolysis, yes or no? So I think the yes has got the majority. Thank you. If we move back to guidelines concerning the use of thrombolysis in pregnant women, and you've got all those who are currently accessible, in most of the cases, we have recommendations which are, of course, of very low level, but it is said that you can do that. It is reserved for life-threatening cases, of course, if you have to save a limb. If we look at recent literature reviews, despite limited experience, this was life-saving in pregnant women with massive PE and severe hemodynamic compromise. But we observe a significant rate of maternal complication, around 5%, and a rate, which is not non-significant, of fetal complication, around 2%. In that case, we moved to intravenous standard heparin. We began low-dose altiplase, 50 milligram mediated thrombolysis. We had an excellent clinical response with recognition in the lung, which was evidenced 3 months later on. We observed minor epistaxis, cutaneous bleeding at the puncture points, no vaginal bleeding, and we could induce childbirth at 37 weeks, 4 days after thrombolytic treatment, 4 hours after cessation of unfractionated heparin treatment. The patient had a normal APTT, a normal fibrinogen level by vaginal route delivery, and she gave birth to a normal, healthy girl. But 3 hours later, 3 hours after delivery, we had a very severe primary postpartum hemorrhage, which necessitated blood transfusion and blood substitution. So we couldn't go on with antithrombotics, and so we inserted a vena cava filter in infrarenal position. Full dose fractionated heparin treatment could be resumed 58 hours after delivery, and the filter was removed 2 weeks after delivery. So the summary for this case: when you manage the massive life-threatening PE with hemodynamic compromise, thrombolytic treatment can be considered. In acute PE with right ventricular dysfunction, in the absence of hemodynamic instability, the latest ASH guidelines don't support the addition of systemic thrombolytic therapy to anticoagulation, compared with anticoagulation alone, of course. So only in the most severe cases which are life-threatening. And intravenous standard heparin is preferred at the initial phase of treatment, along with thrombolytics, and you can afterwards start fractionated heparin after delivery, which might help to prevent recurrent events. Thank you very much.